National Medical Association of more than 20 countries come together and share a common platform. We have a lot of other associations joining us. Today, we have a very, very important topic. We are all worried about what happened in the last 2 years. And during that 2 years, we have seen whether the COVID has been, fearful, fearless. We have seen coming up people saying, do not wear masks. A lot of restrictions are removing out. But one question is still there. Why are deaths still happening? Why are COVID deaths still happening? Is it because of the old variant? Is it because of the new variant? Is it because of long COVID? Is it about comorbid disease? All those things will be answered by none other than Dr. Rahul Pandit. Just a small introduction. He's a director and HOD of critical care of Fortis Hospital. He is a senior intensive care consultant over 2 decades of an experience and is the director of critical care and ICU, having a prestigious fellowship of Joint Faculty of Intensive Care Medicine Australia. Dr. Pandit plays a very important lead role in setting up the ICU policies, protocols, and patient algorithm. He has completed the European Diploma of Intensive Care Medicine. He is an esteemed member of Maharashtra COVID Task Force of COVID-19, the task force who has played a very key role in establishing the patient management protocol for serious and critical ill patients. It is also recommended the requirement of specialist doctors and healthcare support staff in critical care hospital. Welcome to our forum, Dr. Pandit, and we are all looking for the knowledge which you will give to us right now. Thank you.
Thank you very much, Saurabh, and it is indeed a pleasure and an honor to be here today. It is a very intriguingly interesting topic, and if it's okay, I'll start sharing my slides.
Absolutely.
Are my slides visible?
Yes.
Yes, thank you. So this is a very interesting topic. We've talked about this third wave, and we've looked at we reflect back on the last 2 waves, the second wave and the first wave. And we wonder, why are deaths still happening? If we all knew that vaccination is good, if we all thought that Omicron is essentially a very mild disease, then where are these patients who are so sick and why are they still dying? And I have been sort of thinking about this for the last almost 3 months, 2.5, 3 months, that how can we actually bring down our deaths? Me and Professor Shashank Joshi, we often ponder and we often wonder whether we will be able to actually bring down COVID deaths to 0. And just this reflection of the deaths, I actually started looking at deaths across the country in India and a little bit across the world as well. And I thought that there were some pertinent points which we could possibly bring across in this discussion out here today. So this is the data from Johns Hopkins University, looking up to just around 30th of January, just beyond that, 2022. And we all know that the cases which sort of really spurted up in the month of December and January are across the world coming down. And you see UK, USA, Brazil, Russia and Canada, Russia and Brazil are still on the upsurge. But the rest of the countries, they seem to be sort of coming down quite nicely. But when you look at the deaths during the same period, you see that US actually is having almost 2,500 deaths a day. India is still on a little bit on the upsurge. It hasn't really flattened it off. Brazil is still there. South Africa is definitely coming down in terms of the percentage. And Russia, I think, though the numbers are going up, the deaths have always lagged behind, as we all know. They lag behind by at least 2 or 3 weeks. So we will possibly see that graph going up for Russia in a few weeks' time. United Kingdom, it's flattened off, and I'm hoping that it will now start coming down in the next couple of weeks that we look at. So what I've got in my talk is I've got a little bit of reflection of the first 2 waves. This is our own work. in Mumbai, in our hospital, and in the regional setup with a couple of other hospitals together. And we look at the deaths, we analyze those deaths based specifically on comorbidities, age, and gender, and see if we can actually get some learnings out of that for the third wave. So this is one of the papers we published last year, where we looked at deaths in our hospital. So this was an intensive care database of around 514 intensive care patients, majority of them who were on a ventilator. And if you look at just the first graph here, first table here, you can see that patients above 50 obviously had a very high chance of dying. Our mortality was just around 10% or less in our ICU. It has consistently remained low in our ICU, and I will come up to some of the other ICU database as well, and we can look at that. And you can see here that just being above 50 years of age, you were almost having 90% of the patients. And if you compare them between male and female, again, male gender, almost 80% of the patients who succumbed were males as opposed to females. We know that. We know that from before, that female gender has got some estrogen protection. It sort of gives them a lot of protection from severe disease as well, and obviously because of which we don't see them dying that much, which is a good thing. The other very, very glaring reality which is in front is that, yes, you look at the gender, but if you look further deep down into it and deep dive into the data and look at comorbidities, you will realize that almost 85% of the patients who succumbed had comorbidities, and comorbidities in the form of 5 of them: hypertension, diabetes, ischemic heart disease, obesity, BMI of greater than 30, malignancy, or autoimmune diseases. So we know this now, that if you are a male patient, if you have comorbidities, and if you're above 50, the chances of dying are very, very high. That's what this data tells us. After this data was published, just about this data when it was getting published, we actually got hit by the second wave. So during the second wave, we actually looked at a prospective data of around 9 ICUs across the western part of the country. And what we did was we compared between the first and the second wave at the end of it. So we prospectively collected data, and then we actually compared it with the retrospective data between the first and second wave, specifically looking at ICU mortality. So if you look at this first chart here, we've got around 1,900 patients from these 9 ICUs in the first wave, approximately 1,500 patients in the second wave. And if you look at our mortality, the ICU versus hospital mortality, definitely very high mortality in the second wave in terms of percentage, as well as in the absolute numbers. And if you sort of compare that, it went up to almost 26%, 29%, as opposed to 13% and 18%, respectively, for hospital and ICU between the 2 waves. Our ICU mortality in the second wave was only 12.5%. So we were still below most of the averages, even for the first wave. And our Apache 2 scores, our PF ratios have been really, really high. And despite that, our mortality has remained low. Nevertheless, coming back to this reflects us again the same sort of a picture, that if you were above 50, if you are a male gender, and if you're likely to be in the second wave, you're probably having a larger chance of actually dying. And of course, comorbidities played a significant role. We looked at HRCT scores as well. Higher the score, higher was the mortality. So these were sort of a trend which we were clearly establishing. Let's see what trend we are getting across in our state, in Maharashtra. And I'm now only talking about deaths happened in 2022. I'm not talking about deaths happening before that. So we are now here in the third wave. So we looked at first wave, we compared the first and the second wave. Now let's come up to the third wave, which is predominant Omicron, 90% Omicron, 10% Delta in Maharashtra. These are the daily number of cases starting from 1st of January to the 31st of January. And you can see how we had the upsurge here, a couple of humpbacks, and then we have sort of a downward trend since the 31st of January. And the deaths followed the same pattern. We had daily deaths sort of recorded between anywhere between 3 to 63 maximum, and that 63 was somewhere around 19th, 20th of January in our state. And if you could look at the total number of deaths, around 950, and as the cases started to trend down, the deaths went down as well. And they have remained low. We don't have a large number of deaths happening right now. So let's look at this same data in a different way. We are now looking at 2020, which is the first wave in the first column, then 2021, and then just the month data for January 2022. And if you look at this case fatality ratio, age specific, between 51 years to 100 plus years, your case fatality ratio really jumps up from 3.9% to 33%. So 33 might sound much more, very, very high, but look at the number of cases, only 18 cases. And that's why the case fatality ratio is very high there. And it sort of remains exactly the same in the second wave. But the big difference is that despite having larger number of cases, despite having more number of deaths, the case fatality ratio remained less. So we probably can assume two things from this. One is that we had a large number of people who got infected, but not all of them were sick. That's one way of assuming it. The second way of assuming it was that we were probably very poor in understanding the disease in the first year. Now we understood the disease a little bit better, so we were able to save more lives. The third is the healthcare infrastructure probably improved significantly, and that's why the second wave we had a much better outcome in terms of mortality. If you look at the third wave now, the one on the extreme right here, you can see that the demarcation doesn't happen at 50 very easily. It happens at around 60 years and continues up to 100 years. So if you are 60 and above, the chances of having a mortality are much higher, even in the third wave as compared to the first and second wave. If you look at the age-wise distribution, again, 2020, higher the age, 40 and above, you still have a high chance of mortality. But here some disturbing trend is seen. You can see that even between 41 and 50, there were almost 6,200 deaths. And that was almost 11.8% of the entire patients who succumbed. And that's 11.8% is the total number of deaths divided by the number of deaths in that age group. And that is a very concerning thing. We are losing young patients. We are losing young patients in 2022. What happened in December 2021? Well, in fact, the second wave, we even had younger people die. So even up to 31 to 40, there was almost a case fatality of 7.8%. Here you can see a clear demarcation happening, 7.8%. 50s and 60s remained the same, but the younger people were affected more, and they were actually succumbing to the disease. Now let's come now to the third one. And here you can see that it still is a younger age group, which is still having a lot of problems, 41 to 50. But obviously, the older you are, 71 to 80, the trend has not changed. The trend still remains the same. So consistently, elderly age group actually has a lot of problems. This is same data again comparing in three different ways. So this is the 3 weeks between January 27 December to January 26, 22. This is December 6 to December 26, and then this is comparing the 3 weeks during the peak of the second wave. And here you can see that during the peak, the deaths obviously were very, very high. So this was sort of the peak around here. We could see that the elderly patients were dying quite a lot. This was just before we went up to the peak, so the deaths were sort of picking up. They were peaking up there. And then when you look at this database here, which is the 3 weeks of the peak of the second wave, obviously a lot of patients who were dying across the country. Same data is seen in United States as well. If you see the United States data, 75 to 85 years age group, very thick, bold red line and black line here, almost showing a mortality in the range of 30%. The younger you are, the less chances of you dying. But look at this blue line here, sort of went up in the second wave. The same data you see that the younger population between 30 and 40 and 40 and 50 got affected, and we actually lost those young lives in the second wave. And then the third wave, again, it is thankfully coming down. So we were losing younger people in the second wave, which was the worry. This is my current data. Just look at the right column here. I think the rest of the column is our self-explanatory. We only had 75 patients in the ICU, so much less, almost 10% of what we had in the second wave. We had 4 people who died. We had patients who essentially died. All 4 of them had pre-existing comorbidities. So I think we are very, very clear that comorbidities is something which is creating a lot of problems along with the age now and male gender. This is the data taken up from the pediatric American Academy of Pediatrics, and this is until the 3rd of February 2022. And you can see that cumulatively around 18% of the children or 19% of the children were actually affected in this third wave in 49 states. And thankfully, the mortality was extremely low. The mortality reported was between 0.00% to 0.24% of all COVID-19 deaths. And 3 states actually reported 0 child death. And in states which reported around 0.1 of all the deaths were essentially because of COVID-19 in children. So I think the mortality and in younger age group is absolutely low, but nevertheless, we still lost a few children. It's not like children did not die. Did immunization play a role? This is the data from Australia, Queensland, University of Queensland and Flinders University. And you can see clearly the demarcation here is 1 dose of AstraZeneca, 2 doses of AstraZeneca, then 2 doses of AstraZeneca plus a booster with either Moderna or Pfizer. And the 2 universities have compared that. And you can see that those who have got a booster, the chances of dying are less than 0.1%. It still remains for the younger age group, only climbs up above 1% when you're 60 and above. And that still remains same, consistent across males as well as females. So definitely vaccination and an additional dose or a booster dose, whatever we may like to call it, has definitely helped the Australian population at least. This is the data from UK. Again, if you have, this is effectiveness. If you have a 3rd shot taken, the effectiveness of vaccine against Omicron almost touches to 90% plus for the sake of death. If it's only 2 shots, then it just falls short of 60%. So vaccines are working. There is no doubt about that. Vaccines are helping us to sort of go across. If we look at the mortality, and this is a few weeks ago, I could not get a recent data here on US, but unvaccinated population outnumbers the vaccinated population by a huge margin. The slide is self-explanatory. You almost have a 9.8% chance of dying as opposed to a 0.7% if you are vaccinated with no booster. And if you're fully vaccinated with a booster, the chances of dying are just 0.1%. So this sort of corroborates with your Australian data. It says that if you have a booster along with the 2 doses taken before, the chance of death are almost 1%, 0.1% or less, which I think should sort of explain why some of the patients, despite catching up, did not actually go and worsen. So then why are people still dying? I think the first answer which we have is a large population of the world, including countries which are the modern developed countries, have got a huge unvaccinated population. And that is unfortunately the most intriguing part, that why are people still hesitant to take vaccine? And I don't want to get into that debate. I'm just trying to outline the causes which I feel are basically having a problem. The second is that most vaccines which we have currently had an immune escape phenomena seen, including the mRNA and the AstraZeneca. And when that happens, a lot of patients actually got infected. And when they got infected, we actually said that yes, it's a more transmissible strain, it's a more transmissible variant, it's an absolute fact. But we actually built up a very, very strong, wrong narrative, saying that it's mild, it's like a common cold. Yes, I agree, it is less severe, but it is not mild. No, it's still a disease, it's still a burden on the body, especially those who are unvaccinated and elderly population. And I think that's why a lot of people got bought into this mild narrative, and many of them were unvaccinated and elderly. what we could have possibly done is we should have reverse isolated this age group of elderly and unvaccinated. But because this chunk is so huge, the number is so large, we never thought of that, and we never actually did that anywhere in the world. And all of them who got infected in this unvaccinated and elderly population, unfortunately, some of them had severe disease, and they were the ones who actually succumbed to it. That is one of the unfortunate realities. Similarly, a lot of narrative about it being mild, plus people who had COVID before dropped their guard. The COVID appropriate behavior took a backseat, especially in countries like India and the subcontinent, where we had a very, very bad second wave. A lot of us thought that we've got a very good vaccination program which is built up in the country. Plus, we had a very high level of antibodies even before the vaccination began. So we have a good level of hybrid immunity, and we would possibly not have any problems with this virus. So I think that's where that was another concern. So many countries even discussed about mask-free nations. You know, the vaccination where the vaccination was large, was almost covering the entire population. They discussed about going back to normalcy. Nothing wrong in that, absolutely. I think every nation should think about that when the appropriate time comes in. But what happened, unfortunately, was that this narrative again got transmitted through social media, through primetime media, to countries where the vaccination was nowhere near that. And a lot of them again thought, you know, I've been having this talk in India as well, that should we be actually going without a mask right now? Yeah, in some of the cities where the vaccination is 100%, you could possibly think of that, provided nobody goes in and out of the city. But that doesn't happen. You always have a floating population, especially in the metros. And then another narrative which worries me is that this is the end of the pandemic. Let's not worry about the pandemic anymore. I think these are the general things which we all know. I am sure you have all heard of this. And then there are some specific things which are very, very crucial to this third wave. They are very, very peculiar to this third wave. And that is what I call as incidental COVID. A lot of patients who got admitted in the third wave who were actually hospitalized were having incidental COVID. They came in with trauma, they came in with sepsis, head injury, stroke, myocardial infarction, GI bleed. And then when they were sort of tested on admission, because that's what we all are doing, we are actually testing most of these patients on admission for COVID-19, they came out as positive. So the hospitals were full. The ICUs were full because all of these patients needed ICUs to be looked after. A trauma with a liver hematoma had at least a monitored bed allocated to him. A severe sepsis, a head injury, stroke, myocardial infarction, all of them went into ICU in the first few days. And that's how the hospital system sort of got a little bit engaged and again started to fill up. Thankfully, nowhere near the second wave, but that's what happened. But what was the big problem was that all of these disease processes have got a much higher mortality than COVID-19. And when these patients succumbed, we were still writing death certificates in a patient of COVID-19, and they all got labeled up as COVID-19 deaths. So I think that this is actually a very big problem. COVID was not the primary cause of death in many of them. So some of them clearly had COVID as a major problem, where they were hypoxic, they had myocarditis, or they had some form of a COVID affection to the organ, which caused a problem. But what do we talk about trauma? What do we talk about sepsis? What do we talk about head injury? You could argue that stroke and myocardial infarction still could have been a precursor to the COVID-19 or vice versa. But certainly the other 3 or 4 causes, which were very common in our hospital as well, have got nothing to do with COVID-19. Another problem was that did we actually estimate how many people were actually infected? I think no government is able to give us exact number because the infection was so high, the test positivity rate was so high. It was not a deliberate attempt. There were several patients who were asymptomatic, who were not getting tested. And for some other reason, when they presented to the hospital, they were found to be positive. I think the testing strategies were different. Some of the nations tested for positive patients, for asymptomatic patients. Some of them only tested patients who were having symptoms. and a whole different kind of a narrative was being built up, that why should we be bothered about asymptomatic patient. Correct. I completely agree with the epidemiologists. I think there was another concern between the epidemiologists and the clinicians. Epidemiologists looked at a very larger picture, which is absolutely correct. And this is, if there is any epidemiologist in the group, I'm not trying to offend anybody. I'm just giving the narrative that what is the difference between my thought process and the epidemiologist thought process. As a strategy for a region, for a city, for a country, for a nation, for a world, absolutely correct. But again, we need to bring it down to an individual patient. When that individual patient comes into the hospital and gets admitted, and we say that you have COVID-19, and unfortunately it's a severe form for you, many families would just not agree to actually believe us. They would just not believe us. They would think that why are we saying that this patient is critical because of COVID-19, because of Omicron, because Omicron is supposed to be a mild disease. So I think there was this message which somewhere got so profoundly strong that it is a mild disease, that a lot of the patients just could not digest the fact that you still had a virus which was potentially bad enough to actually infect people in a same way as the Delta variant or the variant before that did. To top it up all, the twin pandemic, and this is the Delmicron narrative, the Delta variant as well as the Omicron variant. And you can see this is the genomic sequencing from United Kingdom, looking at 9th of January 2022. And you can see how sharply the Omicron has sort of risen up and almost replacing the entire other variants which were present before. And if you can see that this lower end here talks about days since specimen date to the 5th reported case. So between the first reported and the 5th reported case, it's almost a vertical graph for Omicron, whereas the Delta and the other variants had a more linear sort of a curve which went up and flattened. Of course, now the Omicron curve will also have flattened up. So we were better at saving patients in the initial weeks, but patients who died of secondary complications, we are still unable to stop these deaths. And I think that's where I have my concerns, that we are still not able to stop those deaths which are happening due to complications of patients lying in the hospital. Now, whether that complication can be taken up as a primary cause, or it was never a primary cause like a trauma, but nevertheless the patient still succumbed. Well, most of the trauma surgeons would say that if a trauma reaches the hospital, they should not die, which is correct. Most trauma should survive if they reach the hospital. But unfortunately, we do lose a trauma here and there. And some of the head injuries do have a poor outcome despite best of the care. And I don't know how we will be able to stop these secondary complications and deaths. And I think these secondary complications and deaths will continue even if we have a weaker variant, which if it comes from here on. We could have done some things differently. So some of the nations were very proactive. They gave a booster or additional dose much earlier before November, especially to the high-risk group. Some of the countries we possibly started a little bit later. Now this is a scientific discussion. I think if we would have covered an additional booster dose for majority of the people in the world, it would have been really good. But then there is an inequitable distribution of vaccine. There are 3 or 4 doses for some countries, and there are none for many of them. And this problem is in the real world. We need to come to a solution for the COVAX, where we can actually have equitable distribution of vaccine across the world. And that is the only way in which you can ensure that there is no further new variant which comes up, which is nastier than the one we have seen already. And of course, unfortunately, if it does come, then major population in the world is protected from death. I don't know whether we'll be able to protect them from hospitalization or not, but definitely from death. And it is amply clear that if you're vaccinated, the chances of death are minuscule, absolutely minuscule. With that, I would like to summarize. Unvaccinated, elderly, and comorbid are still the most vulnerable population. No matter which next variant comes, I think these 3 groups are the ones in whom we are going to see the deaths, unfortunately, if they do happen. Vaccination certainly would prevent a death from COVID-19. Incidental COVID is one of the biggest reasons why we are still losing patients, and we are labeling them as COVID-19 deaths. Unless we vaccinate the entire world, deaths primarily due to COVID-19 will not stop. Thank you very much. I'll be happy to take questions and have your views on that.
Thank you, Dr. Pandit, for an excellent presentation and excellent insight. And I have with us Dr. Chong, who is the chair for CMAAO, and we have all other members of the group as well. So we will now open the floor for question answers. Kindly raise your hands and please ask the question. So Dr. Pandit, till the time like people come and ask the question, there's one question on the Facebook. Do we know how many people they lost their life because of the hospital acquired infection and not really a COVID, but they got into hospital because of the COVID, and that what was reported?
I tried hard looking for the data, Saurabh. It's not there in the PubMed, at least right now. Individual people or hospitals may have that data, but it's not in the public domain. But I would guess that there would be a population, a small population, if not large, who would have caught COVID-19 in the hospital and who had possibly succumbed to because of that. That's one way. But I think the bigger question actually is not who got COVID-19 in the hospital. The bigger question is that people who were unvaccinated, who actually became sick enough to be admitted to the hospital and caught a hospital-acquired infection, not COVID, but sepsis or something, and succumbed to that. That is a bigger population, unfortunately. And that could have been avoided. Had they been vaccinated, they would have never come into the hospital in the first place. The death could have been avoided. I think that's the direction we need to be thinking of. We need to get people vaccinated so that they would never come to a hospital to land up with a complication.
Thank you so much. Absolutely. Dr. Sajjad, your question, please.
Yes, thank you very much, Saurabh. A very informative, very good presentation by Dr. Rahul. Actually, I just want to share in Pakistan what we observe as a clinician. I'm an ENT surgeon, Dr. Rahul, and what I have observed as a activist of the Pakistan Medical Association, that the most of the patients are dying because of the denying of the COVID virus, and the people who have vaccinated, they're denying that how can we get the coronavirus, as I have vaccinated already, so no way that I am infected with the coronavirus. So they are denying and they're delaying the coronavirus treatment, and they at the end they deteriorate their conditions, and then they hospitalized, and then they went into the ventilator and then died. So this is the scenario in Pakistan. Even the doctors are, some of the doctors I know, that they are denying that how can I get the coronavirus, because I have already the booster dose also. So they deny and they are doing their work. They used to go to clinic, and when the condition is deteriorating, then they get the PCR test and find that they are COVID patient, and then by that time it's too late. So in Pakistan, this is the scenario. The people are denying because they thought that they are vaccinated, they cannot be infected again with the coronavirus. So I want to know that in India or anywhere in the world, the participants are there, that why the doctors are dying. Any reason you find in India why the doctors are dying? Any significant reason in other parts of the world also? Thank you.
I actually studied the subset of the population of doctors who got admitted with us in ICU. So we were one of the favored destinations, if you would call. Unfortunately, that's not the right way to describe it, but that's the way to say it. Out of my in the first and second wave, out of the 1,300 odd ICU patients, almost 250 were doctors. Unfortunately, a lot of doctors who got admitted with us. We lost only one doctor, and that too the doctor who was our own colleague from our own hospital. Despite being on ECMO for almost 60 days, we lost him. So one of the reasons is that many of us in the first wave and possibly in the second wave actually got exposed to high levels of high viral load. Secondly, I think many doctors, whether we agree or not, at least in the Indian subcontinent, have got multiple comorbidities, and how controlled they are is a big question. Because many of the doctors who would tell me that they were diabetics and they had well-controlled diabetes, when I would do their glycosylated hemoglobin HbA1c, it would be above 7, consistently above 7, and they would not believe it. So I think these are some of the reasons. As doctors, we tend to take our own health a little bit lighter than what we would do for our own patients. And what you said, Dr. Sajjad, is also correct. There is a denial. There is a denial in the general population. There used to be a denial in the doctors as well. I don't see that in the third wave now. In the third wave, doctors are very quick of doing a test and coming to the hospital if required. In fact, in the third wave, I had the opposite. Many doctors, I did not want to be admitting them in the hospital, but they were insisting that please admit us. We would like to stay in the hospital for at least a couple of days, make sure we are okay, and then you send us home. So there was a complete quantum change in the pendulum striking on the opposite side of what we saw on the second wave. And that was more because of the fear of losing life, which they saw in the second wave. The third wave, we did not have that problem, but second wave, we certainly have that problem.
Thank you.
Okay, thank you.
Dr. Angelica?
Thank you so much. Thank you, Dr. Rahul. It is very, very insightful. I just want to say, we keep on saying it is a mild disease for majority of people, but apparently the public out there doesn't understand the term mild. Mild means I can treat you out of hospital. And we keep on saying as well that if you are unvaccinated and if you're above 50 with comorbidities, you have to go and see your doctor, even if you've got a small scratch in your throat. But people, I'm not sure whether people have easy access to doctors at primary healthcare. I'm not sure anymore, because that message seems to get lost as well. And I think you have raised a very, very important issue here regarding the comorbidities. What we have seen the past 2 years in South Africa, first of all, our National Department of Health made a ridiculous rule that for the first year in 2020, you don't need to go and get your repeat prescription at the doctor. The pharmacist will just automatically renew it for you. So we pushed back on that, but by the time we got it through, a year nearly passed. So that led to another thing, that if I am suffering from chronic diseases and I feel okay, because people feel they don't have high blood pressure, they feel they don't have high sugar, therefore I don't need to go to a doctor. And by the time when we pick them up, and they then have COVID-19, it becomes extremely difficult to get them controlled. And then there's still that belief that ivermectin is going to get them out of hospital. And you're absolutely correct that people think if I have been vaccinated or had COVID before, I can't get Omicron. Now, we keep very, very good stats. So what I am currently seeing this past week still, there's about 3 months after you either had COVID or been vaccinated or a combination, that these people are now starting to come in with COVID-19. Yes. And it is a huge concern to me, because we need to be honest with the people and say, yes, please remember, even if you had COVID, even if you've been vaccinated, guys, after 3 or 4 months, if you get a scratch, go to the doctor. Doctor, please test your patient and make sure that their blood pressure and sugar is controlled. We need to get that message out there. I fully agree with you on that. Thanks.
Thank you very much, Dr. Angelique. I completely agree. I think the whole narrative is not built up by any one of us from clinical practice. or even from the epidemiological practice. It is, I think, the media which has sort of got people who have no, I'm sorry to be very honest and blunt, who probably have no understanding of what we are trying to tell. We are never telling them that this is a mild disease, you need to stay at home. No, every mild disease, you need to talk to your healthcare practitioner and you need to get an advice. And you follow their instructions to the T. If they ask you to present to a hospital, you come to a hospital. Unfortunately, that's not how the world media behaved this time. I think a lot of it needs to be changed. I used to come, Saurabh knows that we used to come on the television channels almost every single day. I would be on some television channel, and the same questions would be asked to us, that you are saying mild, why are people getting admitted to the hospital? Well, we never said it's mild to the point that you should not be even worried about it. Even if it's a common cold, you still need to see your practitioner and make sure that you are safe. It's not for the people to judge.
Absolutely, and we must understand the hospital, the doctors and the media is very different, and what is presented in media may not be true, right?
Yes, Sura, can I?
May I?
Just
Manisha Kukreta.
Manisha ji, please raise your hand. We will ask your questions. Just hold on. Ravi, can you please go ahead with your question?
Thank you, Saurabh. Thank you, Dr. Rahul. I've got two questions. Number one, in Malaysia, I'm from Malaysia. The government is currently doing the vaccination for those between 2 to 12 years old. Now, this is a vulnerable group, of course, because they're going to schools and all those kind of things. What is your opinion for these children who are not vaccinated as yet because they are in the process? Of course, there's a big group who are not agreeable to them being vaccinated. But while those who are not vaccinated against those who are vaccinated, for that group of children, I'm sorry, not 5 to 12-year-old. My second question is, since as a healthcare worker, as a doctor now, I'm 60 and above, and we are vaccinated with a booster, but since we have high incidences because of the comorbidities, are we supposed to stay at home? We can't, because I'm a general practitioner, so are we not supposed to be practicing medicine, or what is your opinion, doctor? Thank you.
Okay, so second one is easy to answer, Dr. Ravi. You should be practicing. We have to learn to live with the virus in a safe way. So that safe is the most important word. Safe means you do your regular health checkup to make sure that your comorbidities are well controlled and truly within the range. I have some data which is unfortunately not statistically significant. I'm sort of working on that right now. That those who had a well-controlled diabetes and blood pressure did not have the same stay in the hospital, which was longer, as compared to those who had uncontrolled diabetes or uncontrolled hypertension. I'm working on that data. I don't have the current numbers to give you, but certainly there is a trend that if your comorbidities are well controlled, you are almost like a person who does not have comorbidities. That's what my hypothesis is, but I need to prove that. So I think you should go out. You should make sure your comorbidities are controlled well. And whenever the country has your vaccination program updated, you keep on taking the booster dose or the second dose or the fourth dose, whatever you call that in your local country. So please do that. For children between 5 and 11, so I'm not a pediatrician. I will not be able to answer in a very succinct way as to what should be done. I believe everybody should be vaccinated. That I firmly believe about. I have no doubt about that. But I agree with you. There are a lot of parents and a lot of people who don't want that group to be vaccinated for various reasons. Let's not go into the controversies of that. It's a difficult question to answer. I think they need the equally important aspect of their life is their development as well. And the large part of the development happens in the school. So I think it's a very tough call. It's not very easy. I would say in the light of the current scenario in the world where overall the cases are low, we should allow them to go to school despite the vaccination status. But we should try and do a good public education, parent education program to try and convince them to get their children vaccinated. That would be my thought process.
Thank you. Dr. Chong.
Hi, Dr. Rahul. Thank you very much for that
Brilliant talk and presentation. I just have a question on whether there's any differentiation in mortality figures among different types of vaccines.
Different types of
Vaccines.
Vaccines.
Different platforms.
Yeah. So
and just to add another question, the same question. Also, is there a data where you have from a booster dose and a regular couple vaccine? Like if there are two vaccinations, which is a regular vaccination, and if somebody has a booster, so is there a difference in the mortality rate?
So the Australian data which I showed you between the AstraZeneca and the Pfizer or the Moderna clearly sort of was in the favor of a booster given with either Pfizer or a Moderna, so mRNA vaccine, clearly better there. The difference is very minuscule, Dr. Chong. It's not very high. Indian data, we need to analyze it. I still haven't got to analyze it because in India, we are still using AstraZeneca to AstraZeneca booster. And the other one is the Covaxin to Covaxin booster. So I promise you, as soon as I have that data, I will forward it to Saurabh and he can present it. Or I can come back at Saurabh history and I can come back and present that. No problems.
Thank you.
Pandit, you're always welcome. It's your family group here. Okay. Dr. Sajad, you have another question? And Dr. Chong, please join me for the session forward.
Okay. I actually just forget what I was in my mind. I just forget. I will come back again. Okay, thank you very much.
Send you some elements. Dr. Manisha. Dr. Manisha Kukreja, are you there? Yeah, please ask your question.
I'm here. I have doubts and questions about incidental COVID. The question is that agreed cases, asymptomatic or vaccinated cases may have no symptoms at all. Exposure might have happened, trauma, and say head injury. But sepsis, MI, and stroke cases reaching hospital, how can we call them? They are comorbid people, and just saying that COVID is innocent has not produced this MI or been a precipitating factor, caused further sepsis. I have my doubts about that. And I have a second question. This one can be answered first.
Sure. So trauma, head injury, there is absolutely no correlation between COVID and any of these. These are just things which actually happen as an accident.
Correct.
I did mention in my talk that you could argue and say that the MI or the stroke happened because of the COVID or vice versa. It's very difficult to say. But if you have no respiratory symptom whatsoever, how many cases of pure stroke I saw in the first and second wave with absolutely no lung involvement or upper respiratory tract involvement? Zip, nothing. Similarly, myocardial infarction, zip, nothing. So we saw combination of COVID and MI or COVID and stroke with thrombotic complications in first and second wave. But if you actually look into the history, clinical examination, most of them had some amount of respiratory tract involvement, at least some amount of it. Of course, you will find one-off case which will be completely, cold from COVID point of view and have only MI. And you could argue that that is just a thrombotic MI which we are seeing. And I would not be able to defend it. But I think most of these patients actually primarily did not have COVID. Had the test positivity rate not been so high, we would not have found COVID in these patients. I am, at least in the third wave, I am very, very convinced about it. I think the test positivity rate in some of the places in the world was as high as 30-40%. That means 4 people in the house, 2 of them were likely to be positive. And if one of them had an MI and came to the hospital, was labeled as an MI with COVID. Now, that's where we were. A lot of them just got better with the MI treatment. We never treated them for COVID at all. We never gave them anything for COVID-19.
That's agreeable. Only my statement is that COVID is not only a respiratory disease. It's a thrombotic, it's inflammatory leading to these. Okay, agreed. And the second part is, does Omicron, like the previous Delta, Beta waves, have long COVID, and what are those? I mean, I'm still looking for some of those.
So
cases.
we actually run a very comprehensive long COVID OPD. and outpatient department. And I can assure you that I have not seen that many patients coming up to me right now with long COVID. Now, we actually thought long and hard about that what happened. Is Omicron not having long COVID as a complication? I don't agree with that. I think there would be a large number of patients who would be having some amount of problems. But I think the service which we were offering in the first and second wave now is offered by many people. A lot of people understand about long COVID now. Previously, we were exclusive. At least in Mumbai, we were only a couple of hospitals which were doing that. Now there are a lot of physicians, a lot of general practitioners who are able to help these patients out, and perhaps they are not reaching to us. So I think there is still long COVID there. Definitely body ache, lack of sleep, lack of appetite, sleep wake cycle. Those are still the complaints which I'm seeing in Omicron as well. But may not be very different to what we have seen in the second wave.
Right. I
Sorry, Manisha, you got mute. Can you please unmute and ask? You were saying something.
Can I ask one question?
Kiranji will call you.
I said I seen some of the people having excessive sleepiness. I mean, something different from the other two waves. Body ache and, yeah, lethargy and sleepiness, you can say. Thank you.
Lethargy is certainly there. A lot of people feel weak and lethargic. Increased somnolence, I have not seen, but I would not be surprised. I mean, I think we need to record these findings and keep on. If you see a pattern, we need to publish them. So if you do see a lot of patients who have complaints of a lot of sleepiness or daytime somnolence, then I think we'll have to just record those patients, get some data and publish that. That would be a very good finding to actually know that whether this precipitates like that.
I have 3 of us complaining.
So thank you.
Okay, thank you.
Dr. Akhtar Hussain, please your question.
Yeah, thank you, Saurabh. Thank you, Rahul, for excellent information on your presentation. My question is, and one of your slide, pediatric age group, the mortality almost some of the countries is showing 0. In compare with the adult population is very different. So
Pediatric, you mean?
Pediatric age group mortality, so some of the area you said there's a 0 mortality. So what is so different between pediatric age group? We know the comorbidity is there in even children and pediatric age group. So what protecting children not to have a severe and death?
So again, I'm not a pediatrician, Dr. Hussain, but from what I understand about the immune system, the thymus gland, which is active till at least 9 or 10 years of age, offers a large amount of protection to these children. And that's thankfully the case because all of us love our children more than ourselves. So it's actually good that they have got a lot of protection naturally from the virus because of the thymus gland. And that's where the T cells are robustly produced. If there's any pediatrician on board, he or she may be able to explain that in a better way. But that's my understanding of the problem. And that's why they are spared.
Okay, so I would like to invite Dr. Alvin, and who is also a pediatrician. So Dr.
Okay.
Alvin, please ask your question. Oh, sorry, you got mute again. Yeah. Okay.
Thank you. You can see that I am fully geared because I'm still having my clinical practice on Saturday.
Dr. Alvin, just a minute. I love your mask. I think there's a very nice smiley on your mask.
Yeah, just to keep my patients relaxed, you see, because in Hong Kong, everybody is very tense now. In fact, we are also at the explosive surge of the tsunami Omicron wave in Hong Kong now. Although 82% of Hong Kong people have been vaccinated with the first dose, for the age group under 11, we had just started the vaccination exercise since 10 days ago, and only about 10% or up to 20% less than 15% of our population under the age of 11 have been vaccinated. In fact, so this is a loophole in the defense in our community. That is, well, for most of the other age group, it had been more vaccinated already. But then in the pediatric age group, under 5, the vaccination coverage is 0, of course. Even USA had refused to consider this at the moment. But of course, even at the 5 to 11 years age group, we are less successful as that in Singapore, I think. So this less vaccinated age group will become the loophole that the virus will get into. And so in the past 2 days, there's one very sad incident in Hong Kong, is that a 4-year-old boy had succumbed being COVID-19 positive, and he had vomiting and just fell very sick very soon after he got the disease, and we had not yet been informed of the autopsy result. All right, but of course, I think it is well known that the COVID-19 could cross the blood-brain barrier, and in fact, the choroid plexus with the inflammation, and then also then the meningitis and encephalitis. Just now we had talked about the long COVID. In fact, there are studies from Israel and other places that 11% of children with COVID-19 could have long COVID. And the long COVID symptoms are not just respiratory or in general, but they could have loss of concentration, that is attention deficit. They could have memory problems, that is the people had lost some of the short-term or even long-term memory, and that they could have a very much mood affected, say anxiety and insomnia and depression. And so I think the productivity of the individuals, the learning ability of the children would be affected. And so this is, of course, important, especially the parents are very concerned. And so this could become a driving force for the parents to allow the children to get vaccinated, because previously most of the parents are very, very dubious and hesitant to let their children to have vaccination. So now perhaps the parents are more motivated to get the children vaccinated first, to prevent the elderlies in their families to get infected, because just as Dr. Pandit Rahal had mentioned, age is such a significant factor, and comorbidity is such a significant factor in the morbidity and mortality of patients infected with Omicron. And in fact, I think the vaccines are going to be also universally given to the children in the community, in my opinion. Just now, I think we have to be very prudent to protect ourselves from getting infected, because even if we are asymptomatic with the confirmation of Omicron infection, still we have to have home isolation and quarantine. And that is, if we are infected, our clinic will have to close down. And in the community, there will be one less clinic functioning. And if we are doing hospital work, the one more manpower workforce will be eliminated from our service. And that is detrimental to our efforts in fighting this battle. So we have to be very stringent, vigilant in protecting ourselves from getting infection. But of course, well, this is sometimes very difficult to be assured, but we still have to try our best. Again, thank you very much, Rahul, Dr. Pandit, for giving us the excellent lecture. So I think it is not really well known now about the epidemic. I mean the experience in children getting Omicron is not yet fully known to us now, because the history of Omicron is only just 2 or 3 months. In Hong Kong, it's just only 1 month. So we still don't know about the state of morbidity, and mortality in the pediatric age group. So on the whole, it seems that it's mild. On the whole, it seems that morbidity and mortality is low in children's age group. But as I said just now, we already has the first fatality report in our pediatric age group, and that's below the age of 5 that could not be vaccinated in our community now. I mean, all over the world. So thank you very much.
Thank you very much, Dr. Alvin. I completely agree. Just a couple of comments on what you said. I mean, just complimentary comments. Around 8 to 10% of the medical population, the healthcare workers, were infected during the peak in my hospital. So we were at least 10% short at any given time for at least 3 weeks, 3.5 weeks. We always were juggling with the rosters, whether it was nurses, junior doctors, consultants, directors. Everyone went through one round again, and we were always 10% short. About COVID encephalitis, so there were, I know a couple of pediatricians and pediatric neurologists. As I said, I'm not a pediatrician, who have actually gone ahead and done a lumbar puncture on these people and tested for RT-PCR on the CSF fluid. I don't know how sensitive that should be or how specific that would be, but they did find RT-PCRs to be positive. I had actually suggested them to do some viral culture and find out if they can actually cultivate and see, but it didn't happen. So we sort of just stopped with RT-PCR coming positive. But that would be something interesting to see whether we are able to cultivate this virus and culture this virus and see whether the viral copies are, or maybe how many viral copies these people had. It's very difficult. Theoretically, we can talk about that. Practically, it's not possible to do.
Thank you. Can we have a quick question from Kiran, Dr. Kiran?
Yes, I have a small question. That have you been experienced the role of CoQ10 in post-COVID myalgia and all, fatigue, myalgia, CoQ10?
Sorry, Dr. Kiran, can you again repeat that? I did not get. What is the role of what? CoQ10?
CoQ10.
Coenzyme Q, you mean?
Yes, yes.
Yes. So coenzyme Q is again a complementary drug. You can use it. I don't think it works in anything, but I don't want to be dismissive about it because we don't know enough whether it actually works well in post-COVID syndrome or not. But it's certainly a complementary drug which can be used. I don't think it can be used as a monotherapy. A lot of people do use coenzyme Q, and I think it's harmless. If at all it benefits, it's worth trying it. But whether to say that it's a prime time therapy for post-COVID syndrome and for which type of symptoms, it's very difficult to say, Dr. Kiran, right now.
And if it is to be given, it should be given for 2-3 months?
I have no idea. I am not somebody who has used it, but I can find out for you if you want, and I can pass that on. Okay, there are people who are using it regularly, I know that, but I am not certainly the one who has used it.
I prescribe to few people, and they are saying myalgia fatigue is really not there.
That's good.
Great. Dr. Prakash, your question, please.
Yeah, good morning all, and thank you, Dr. Rahul, for the wonderful presentation, and all the participants. Good morning from Nepal. In post-COVID, compared to third wave, in second and first wave, we have a more percentage of post-COVID patients. And we can say in compared to second, in first is more post-COVID. But how long it will remain as post-COVID or long COVID? Can you say, Dr. Rao?
Okay, so as I said, we run a post-COVID clinic. I will give you 3 anecdotes. One is my own experience. The other is my own experience when I got COVID. I am talking about my own experience as a patient, not as a doctor. Then the patients which we see in our hospital, and my interpretation of what we are seeing in the third wave, which is the Omicron wave. So I got COVID in May 2020, in the first wave. And trust me, doctor, I could not sleep normally as I would sleep until December. So it almost took me 5 or 6 months for my sleep pattern to set back. That was the only complaint I had, that my sleep, I used to wake up frequently, and at times I would not sleep at all in the night, just toss and turn and have only few hours of sleep. And this is for somebody who for the last 23 years has been sleeping like a baby every night, gets called 2 or 3 times in a night from the ICU, did not bother me at all. I would pick up the phone, do a conversation, and fall to sleep in the next minute. But it took me almost 6 months to find that sleeping pattern again. So one thing is it can continue for 6 to 12 months. Yeah. From our patients, we are seeing patients who are coming to us almost for 6 to 12 months. The major problems which don't settle down are the sleep-wake cycle, resting tachycardia at times. Third is feeling of weakness and fatigue. That doesn't go away very quickly. People feel tired by working for 4 hours. It's almost like they've put up a 12-hour day already. These are some of the symptoms which persist beyond 3 to 6 months. In the third wave, unfortunately, a lot of patients have not come to the hospital at all. And as I said, they are not actually presenting with long COVID to the same numbers of what we got before. I believe there would be same amount of patients there, what we saw in first and second wave. It's just that they've got distributed across the healthcare spectrum now, and they're not concentrated to hospitals.
Thank you, Dr. Rahul, for explanation.
Thank you, Dr. Pandit, for an excellent question answer. I'm sorry I took more time than what I committed to you. Dr. Okay. Pandit has been joining from Australia, especially he's in traveling. He's in Australia right now with a beautiful sunlight next to him. Dr. Chong, you want to address the session?
Thank you very much for that wonderful session, Dr. Rahul. Always a pleasure to listen to good speakers, and very, very clear. I think at the end of the day, mortality in COVID is really something that is quite something that we know of, but we never really go to analyze those particular figures. And I think we've learned a lot today from the analysis. So we are usually, most of the time, we're concentrated on morbidity, and in my country, we have 800 over deaths from COVID in the last 2 years, and the majority of them are actually elderly with full of morbidities. So sometimes, and our public sector hospitals here also tend to be quite unforgiving of the age number, if you know what I mean. Once they see a certain age, they'll kind of almost to the extent of not try too hard, or start talking to relatives. Oh, we're not going to tube him. We're not going to do this. We're not going to. So unfortunately, that's also been one of the not so good sides about mortality. That it's in fact a symptom of rationing as well of healthcare resources, which is unavoidable when you have a pandemic. Honestly, we don't have all the resources in the world to cope with everybody, and we still have in Singapore 38,000 unvaccinated elderly who just refuse to be vaccinated, despite all efforts and cajoling and even differentiation measures. You can't go here, you can't go there, we restrict you, and even then they are completely just refuse to be vaccinated. So it's quite a telling kind of insight into this part of the pandemic that we usually don't really think about, if you understand what I mean. So On behalf of everyone, I think I'd like to wrap up the session. If there are no more questions, it's almost time for us to close shop. And I'd like to thank Dr. Rahul for that beautiful, brilliant presentation on a topic that really, there's more than meets the eye. It's a tip of the iceberg, if you know what I mean. Thank you very much. And goodbye to everyone, and happy Lunar New Year as well.
Goodbye and happy New Year. Bye-bye. Thank you.
New Year. Happy New Year.
Thanks.
Bye.